We're going to have the first technical session on emergencies at workplace. And for this session, I would like to invite Dr. Prashant Saxena, Director and Head Pulmonology, Critical Care and Sleep Medicine, Fortis Hospital. Everyone, let's give him a warm welcome to the stage. Please give him a round of applause. He's going to talk about on respiratory emergency. And now over to Dr. Prashant. Sir, thank you so much for coming.
Thank you. And at the outset, I would like to thank the organizers and for giving me the opportunity to be here in this mega event. It's a pleasure to be part of such educative events. And I am Dr. Prashant Saxena, and I am a pulmonologist and critical care expert. And I practice at Fortis Vasantkunj and Fortis Hospital, Gurugram. So, there was a question which was asked, and I still believe that lungs are the most powerful organ of the body because every organ of the body needs oxygen, and without lungs you cannot absorb oxygen. So they remain the most powerful organ, and respiratory emergencies remain the most important emergencies to deal with in an emergency setup. Very frequently we find people coming up with severe cough, chest pain, breathing difficulty, oxygen saturation going down. And they present to us in different ways, either in the OPD or in the emergencies. And many times we are actually confused, or we are not able to clearly understand what exactly is the presentation like and what exactly we are dealing with. So I made it a bit simple so that everybody could understand. And it's a case-wise presentation of few common ailments which present to us in the emergencies. So this is a case of a 48-year-old gentleman and who was having shortness of breath and pain, chest pain, acute chest pain for 1 day. He has been a smoker of 20 years, and other vitals you can see. The remarkable thing was his saturation was only 88% on room air. So obviously this patient needs attention. We did a ABG which again showed that the patient had a low oxygen level. His other counts were okay. X-ray was done immediately, and you can see that in the X-ray there is a pneumothorax on the right side. So this is one such acute presentation in a patient with a bad lung or in a patient who has a sudden fall. You can have a pneumothorax on the right side presenting as an acute chest pain. So this patient immediately required oxygen support and had to be inserted a intercostal drain, which usually we insert on the right side because it was the right and fifth intercostal space, and then the patient improved. So any patient who presents to you with a pneumothorax, we have to give a high flow oxygen. Obviously you don't know whether it's an infection or not, so antibiotics are a wise option. Plus you can, because this patient was a COPD patient, he was a smoker. So we gave him bronchodilator nebulizations and analgesics because ICD was inserted. And you can see after the ICD insertion, the lungs have expanded beautifully. But on the CT scan, is there a mark pointer here? No. So on the CT scan, you can see there is a large apical bulla, which I have marked on the right side. So these people who smoke a lot, they develop bullae in the lungs. And these bullae tend to explode whenever they cough vigorously. So this patient definitely had a secondary spontaneous pneumothorax, which means a pneumothorax which happens after a disease, which is a COPD. Primary or spontaneous pneumothorax means a pneumothorax which happens in a patient with a normal lung. So this was a secondary spontaneous pneumothorax, and due to the bulla, this patient had a chance that he can have another pneumothorax, so we did a pleurodesis. Pleurodesis is a procedure in which we instill talc into the pleura so that the pleural membranes, they become adhesive to each other and there is no chance of recurrence. And this patient was sent happily home. Then another case of a patient, 77-year-old lady, presenting with a chest pain on the right. And she has shortness of breath. She has a history of a pacemaker insertion, AF, remarkable history. And her saturation was borderline 91% on room air. and she was tachypneic. We did an X-ray, and you can see on the right lower base, you can see there's opacity there with air bronchogram. So we had no doubt that we are dealing with a case of pneumonia. So pneumonia frequently presents as an emergency because sometimes, you can have nowadays very rapidly progressive pneumonia, especially if you have an atypical flu or you don't know, even COVID and other viral infections, they are very rapidly rampant and they can just crash you like anything. So you have to be very careful with this, and without delay, these patients require antibiotics, which we had given to this patient, and nebulization if you feel that the patient has bronchospasm, and the usual medicines were continued. And because this patient was having comorbidities and coming from the community, we did a bronchoscopic culture, a lavage which was done. And from the right lower lobe, you can see there is a big consolidation there, and we grew Klebsiella, which was sensitive to the antibiotics. And then after a 7-day antibiotic course, the patient improved and the patient was sent home. So this just highlights the importance of early intervention in a patient who is very sick, and you can easily grow a bug, and then you can tailor and direct your antibiotic therapy to these patients. This another case of a 62-year-old gentleman, and this gentleman presented with shortness of breath, and he was drowsy for a day. He was not able to talk properly. We knew that the patient was a COPD patient with diabetes and hypertension. He has been smoking 30 years and had quit it. But we could see that the patient was drowsy, he was having flapping tremors, saturation was only 86% on room air. So this is a very typical presentation. ABG we did, it is showing PCO2 was high, so it is a type 2 respiratory failure. This is a usual presentation of a patient with COPD exacerbation, where you can have any infective or non-infective exacerbation leading to decreased airflow in the lungs, leading to retention of carbon dioxide. So this patient was managed with antibiotics. You can see the CT scan again showing COPD changes. And so usually we don't do CT scans, but for patients who are very sick, once they are stable, you can do a CT scan to see how the lung looks like, because that can give you an idea about the future course. And this patient was given all these BiPAP support because, non-invasive ventilation is one such modality which you should use in a COPD patient with a type 2 respiratory failure. Because these patients are not able to breathe at all, so they need a support along with antibiotics, steroids, bronchodilator nebulization, and then once they become better, physiotherapy, breathing exercises, and you can do a pulmonary function test once they are fit for discharge. So this is how a basic management of a COPD patient should be done. But don't forget that these require a non-invasive ventilation. And severe COPD is very common. Please remember that often we take history of smoking. And if the patient is a non-smoker, we think that there is no COPD. But let me tell you that almost 40 to 50% of the COPD patients don't have smoking history. Because of the environmental influences, there's so much pollution and other influences. So we have a non-smoking COPD also. And NIV, as I told you, is a gold standard of first mode of therapy where you should be instituting it in a patient who presents to the emergency. And so this is another case. Now this is a frequent presentation of patient coming to you with vomiting or coughing out blood. And this patient came to us with hemopsis, or blood in the sputum, multiple episodes. And obviously if blood is coming out, then everybody is scared, including the doctors, because it's so difficult to manage these patients. Hemopsis, if it is massive, then the patient can aspirate, the patient can just collapse and die. Because the blood, once it goes inside the lungs, it tends to clot. And thick clots, they don't let the air go inside, and the patient dies of a hypoxic respiratory failure. So hemopsis is a medical emergency which has to be dealt with immediate priority. And this patient was a CABG patient on ecosprin, so there was a risk factor of bleeding. And you can see in the CT scan on the upper portion, there is a ground glass opacity. And this is the region where there was if I can show you, no. So this is the region from where the bleeding was there. So these patients Obviously, apart from the hemostatics and antibiotics, supportive treatment, these patients require a investigation of the airway. So we did a bronchoscopy. We found that the patient was having a fresh bleeding. Now with a bronchoscope, you can instill local adrenaline or tranexamic acid, but sometimes it is difficult to control the bleeding. So these patients sometimes, in a case of persistent hemopsis, require bronchial artery embolization. It's a procedure like a coronary artery angiography, where you go inside a pulmonary artery and instill a dye and see the arteries. And if there is a leak, you put a coil, or nowadays you have got particles which you can instill, and that area gets sealed and blocked. So it's a non-invasive procedure. You just need a prick, and the results are dramatic, and this patient underwent it, and the hemopsis was controlled. So for management of such patients, please remember that apart from the routine workup, imaging, x-rays, importance of bronchoscopy, and then if bronchial artery embolization has to be done, please do it early, because you don't want the patient to collapse. Sometimes, if the bronchial artery embolization cannot be done or is not successful, and the bleeding is localized, you may even have to undergo a surgical procedure, a segmentectomy or a lobectomy, to remove that part of the lung. So this is all the management principles which I have told you of a hemopsis patient. Now this is another patient with shortness of breath and cough, and this patient was having pain in the limbs. And you can see the x-ray is a bit dirty, it shows prominent bronchovascular markings. There is no travel history or any surgery. But his blood pressure was 90/70, and he was tachypneic, and we could easily see there was a right lower limb edema. Now with this, we had a suspicion that this patient could be having a pulmonary embolism. And the first investigation we did was a CT pulmonary angiography, and you can see that in both the major pulmonary arteries, there is a big thrombus sitting out there. Now, these patients require a immediate thrombolysis, which means you have to rule out the contraindications of thrombolysis and give thrombolysis. This patient denied a thrombolysis because you have to explain them intracranial bleed and other things. So, in this patient, we did a catheter-directed thrombolysis. Now, catheter-directed thrombolysis is nothing but a procedure where, like an angiography, you go to the pulmonary artery, and in the pulmonary artery, you inject the alteplase there. So it's a localized thrombolysis, and systemic side effects are less, and there is bulk of evidence to suggest that the bleeding risks are much less. So catheter-directed thrombolysis was done in such patients, and we could easily save this patient, and he was discharged. So please remember that the gold standard is to do a CT scan pulmonary angiography in such patients, and then immediately, if there is no contraindication, consider thrombolysis. Thrombolysis can be systemic or catheter-directed, so that you can save the life of such patient, because pulmonary embolism patient will not give you much time. There is hardly a few hours which you have. In that, the patient can either improve or the patient won't survive. So another case of a lady, and she has asthma, and she came to us with a saturation of 90% and chest tightness and wheezing. And you can see that this is ABG showing a type 1 respiratory failure. The lungs obviously are a bit dirty. And then we did a CT scan. The CT scan, unremarkable. There is nothing much in the CT scan. So this is the acute case of asthma. You know, even if you have asthma and you are on inhalers, you are well controlled, sometimes you can develop a severe attack whenever you are exposed to a trigger. And that presents as a medical emergency. And these patients are tachypneic. Sometimes they become hypoxic and may just collapse. Because, you know, there is so much tachypnea that they become tired. So oxygen was given and then nebulization, and this patient improved. It's a simple case. Now this is a case of an industry worker, which is a plastic toy factory. Now he was working, and there was a fire which broke out, and this patient was brought to the ER. And the GCS was low. You can see the GCS is 6. There is tachypnea. Saturation is 72%. So obviously, this patient was exposed to the fumes. We did a CT scan. You can see the CT scan shows bilateral areas of opacification, which is bronchiolitis. And this patient was hypoxic, 72% was the saturation. So immediately these patients this was intubated, and we gave him fluids because the patient was dehydrated, along with nebulization, steroids. And the important thing which I want to highlight is toxic fume inhalation at this point. You know, nowadays, because of pollution, or maybe you are working in an industry where you can be exposed to phosgene, carbon monoxide, methyl isocyanate, chlorine, ammonia, hydrogen sulfide, sulfur dioxides, nitrogen dioxide. There's so many things. And if you are sensitive, then you can have a lung injury where ARDS, which is a dreadful complication of such exposure, can develop rapidly. Immediately, in a few hours, the patient, which is looking like a normal patient, can just collapse and die in front of your eyes. And then later, the bronchiolitis develops, which is a problem which again leads to debility and a long-term treatment. So these patients have to be told about exposures, and you have to prevent them from getting exposed. And definitely, once they are suffering from such a problem, intensive care is the only treatment for these patients, because you cannot manage these patients in a non-emergency setup. And there are many things which can be done, which I will not be discussing here. So another important factor which we should remember is hypersensitivity pneumonia. You know, nowadays we are seeing a lot of allergies, and people going to farms, people going to hill stations, people going to some areas where they suddenly develop breathing problem and then coughing, and then they come back and people say ki viral ho gaya hoga, cold ho gaya hoga, and then they give you antibiotics and you improve, and then you develop the same thing again. But there is one entity which is known as hypersensitivity pneumonia. Please remember, it presents as dyspnea, cough, and chest tightness. And you have to be aware of this entity, because if this thing is not identified and controlled, it can lead to interstitial lung disease, lung fibrosis, and even debility. So these are the major causative causative sources. And you can see this. There is due to poultry, due to pigeons, and due to fungus, due to mold, potato riddlers, mushroom workers, tobacco plants growers. There's so many areas where you have to be careful in identifying this. And they usually present with a CT scan like this, bilateral nodules in the lungs, and a very bad CT scans. And we have to do bronchoscopy and biopsy to prove that there are granulomas in the lung, because it has got granulomas, because it's a chronic disease. And then definitely treatment, steroids and all, supportive treatment, nebulization, and antigen avoidance. You have to identify the antigen. Sometimes you may have to do allergy tests. And finally, anaphylaxis and the workplace. This is very important for us to note, that you can have potentially fatal systemic allergic reaction that occurs suddenly after contact with an allergy substance, maybe at your workplace. And work exacerbated anaphylaxis is a known entity, and it can be precipitated by any allergen in the community or in the factory or any place we are working. The important history is that it usually occurs within 20 minutes of exposure. So that is the clinching point. And these are the causative agents like latex. You can have insect bites. People who are working in food industries, like nuts, seafood, spices, cereals, soybean, cow milk powder, hen's egg powder. There's so many things. Even people who are working in chemical industries, disinfectants. These are so commonly known entities which are there. And you have to be careful about this, because anaphylaxis requires immediate hospitalization and treatment of anaphylaxis. So this was my last slide. Thank you. And again, it was a pleasure to be here.